Started your time.
Yes, ma'am. Yes, ma'am, I'm ready.
You have to complete, you have to organize yourself for that 2 minutes time, okay?
Right.
Started timing.
Hi, I'm Shaista, one of the exam candidates. I have read the instructions and ready for social discussion.
Okay. So, Dr. Shaista, what are the risk factors for anal sphincter injury for OSS or third or fourth degree perineal tear?
Yeah, so the risk factors are related to the mother and the baby and at the time of the delivery. The risk factors include if there is prolonged second stage of the labor, if there is instrumental delivery, if the size of the baby, if the weight of the baby is more than 4 kg, if mother is obese, and if this is if the mother is primary gravida and difficult instrumental delivery, and if there is also the midline episiotomy. These are the risk factors.
Okay. Mm, okay. Once this patient has now experienced a 4 degree perineal tear, uh, how you are going to repair this case?
So, as this is the obstetrical emergency, so first of all, I will check her vitals, whether she's bleeding heavily or not, and involve my consultant, anesthetist, OD staff, and the specialized nurses. Um, is We will check her vitals to see the status of the patient and severity of bleeding, and assess the patient preferably in the operation theater to check and see the extent of the tear, whether this is confirmed 4 degree tear. For that, the surgery will be done in the theater under good analgesia. Epidural is preferable under good light and with experienced staff. And for that, we will take the consent, the written consent, and patient will be shifted to theater for that. So before stitching, we will make sure that bladder is empty. We will examine the patient and assess the perineum, including the vulva, vagina, and I will make sure that trolley is complete for the assessment. And after vaginal examination, we'll do the rectal examination for the confirmation of 4 degree perineal tear and chain the gloves. And after that, once it is confirmed, it should be stitched either by ST5 or senior than that, or the consultant. And first, we will repair the anal mucosa uh, by by continuous or interrupted by interrupted or continuous stitches better to have interrupted stitches, and the knots will be inside the anal mucosa. And after that, we will check the external anal sphincter and internal anal sphincter. For external, for rectal mucosa, we will use the Vicryl 20. For external and external and internal anal sphincters, we will use the PDS, and because they are less irritant and absorption time is prolonged. So there is no difference between overlapping technique and end-to-end anastomosis. So if there is, we will check whether this is partial. Definitely, there will be the complete torn of external anal sphincter. So we will opt. We can opt for end-to-end or overlapping technique. And for the internal anal sphincter, we will stitch by PDS, and we will apply the mattress sutures. And after that, we will stitch the vaginal muscles and the vaginal skin by interrupted or continuous stitches. And at the end, I will make sure that the swabs and needles they are completed, and even before the stitching, we have to rule out the buttonhole tear as well. And at the end, rectal examination will be done. And after
Okay.
that, mm, we will document, debrief, and incident report will be done. And patient will be debriefed about the procedure.
Okay. Now you have uh, sutured it, and now you are planning to discharge this patient home. Okay. So, what are your check before discharging this patient?
So again, before discharging the patients, once I am going to discharge, I will introduce myself, confirm her identity. I will inquire about her complaints, whether she has any pain, bleeding, how is her lochia, and whether she has passed the urine and opened her bowel. I will check her notes, and particularly her procedure. We will check the documents related to her procedure and post procedure notes. I will make sure that her needles and swabs all were completed after the procedure, and and all the treatment related to after delivery it is written and patient is going to follow. Like she has been given antibiotics for 7 days, and I will check her. I will ask the nurse to check her vitals, and I will check her perineum to see the status of the wound. And after that, she will be informed about the procedure to the GP and the midwife in the community. She will be instructed about the perineal care, wound care, and antibiotics, analgesics, and she has to be advised to avoid the sex. Yes, ma'am.
Okay. Now
So at the time,
you have discharged these patients. So what will be your advice to advice on discharge?
At the time of the discharge, I will advise her that the compliance with medicine is very important. She has to take the antibiotics for at least 7 days, and she has to take the stool softeners for at least 10 days. But she must avoid the bulking agents, avoid the sex for 4 weeks. She has to avoid the tampons. And pelvic floor exercises will be indicated under the supervision of physiotherapist, and she has to maintain her symptom diary, including the bowel flutters and related to bowel flutters and fecal incontinence. And at the time of discharge, she has to be informed that the risk of recurrence of same condition is 5 to 7 out of 100 women if there are if she is asymptomatic after 1 year. And I will assure her that 60 to 80 out of 100 women they completely recover after 1 year of the procedure. And again, GP will be informed, and she has been given emergency numbers, 24/7 emergency numbers, and she has to be advised about perineal care. and she has to and follow-up appointment will be given at 6 weeks in the perineal clinic with the consultant.
Okay. At 6 weeks now, you are seeing her. How will you approach these patients?
Yeah, so at 6 weeks, I will again inquire about her symptoms. I will check her symptom diary related to her voiding, her if she has any flutters or fecal incontinence at daytime, and I will inquire if she's on any contraceptives and any problem with breastfeeding, and if she's on contraceptives, what kind of a contraception she's on. Otherwise, I will refer her to the family planning center for reliable contraceptives. If she is symptomatic, then she will be needed endo-anal ultrasound or manometry and referral to the colorectal surgeon. And if she is asymptomatic at 6 weeks, at that time she will be discharged and documented at that time. And we will again inform her about the incident report. We will discuss that at that time.
Okay. And now she's
And
worried about her next pregnancy. What will be your advice regarding the for next pregnancy?
and one more thing, ma'am. At 6 weeks, we will check her perineum as well. So it's once she is in her next pregnancy. In that case, her care will be in consultant-led unit. Her pregnancy care will be same like her in her previous pregnancy, but she will be instructed that after 36 weeks she can have perineal massaging, and we will inquire about her symptoms at that time again. If she is symptomatic or her scan is abnormal, in that case, plain cesarean section will be indicated. And if she is asymptomatic and her scan is also normal, in that case, she can opt for vaginal delivery. But during the vaginal delivery, there will be perineal massaging, um, hot compression, this warm compression, and perineal support will be given. And we will prefer mediolateral episiotomy instead of median episiotomy if indicated.
Okay.
And this way, I will manage the case.
Thank you.
Thank you, ma'am.
Okay. So your own reflection, and then anybody can comment on her presentation. Dr. Shaista, your own
And
reflection.
my reflection, the initial unexpected questions, I whatever that was my remote memory I was talking. Uh, but I don't know, maybe there were some wrong information at that time as well.
No, it's
Uh,
also the answers were correct.
and and otherwise, I think time management. I maybe in the last I was I was not able to manage on the time. I left few points.
Mm. Anybody can comment on her performance. Anybody would like to comment?
I'm inquiring about breastfeeding, ma'am. I was not there
She,
at that time.
she has mentioned something regarding breastfeeding.
Okay.
Yes.
Yeah,
Okay.
she has mentioned. Mm, okay. Mm, overall, what I feel, a good knowledge part is very good. You know how to approach structure discussion also, but there were quite a repetition. I wanted it to be more, little more structured way. Hmm?
Yes, ma'am.
Yeah, minimize your repetition. Although you used all medical language, you never used any layman language. That was the plus point in this overall conversation. So I found it means quite okay, but can be improved to the extent so that it will look more structured, more precise. That is my comment on this uh, presentation. Okay, communication with patient and family domain whenever it is assessed in structured discussion. I always insist that you, whenever the examiner asks something regarding the patient's situation, you say somewhere that I will introduce myself to the patient. This way you are going to be marked in communication with patient and family domain in structured discussion. Okay, you will be explaining, means when I asked you regarding how you are going to repair, at that time also you can introduce. So I will introduce myself. Okay, so something
Yes.
like that, that is a communication here actually. Communication, explaining pros and cons of the procedure, taking consent of the procedure, so those points will come into communication with patient and family instrument. Okay, so that is one observation. Overall, good knowledge need more practice, so that
Yes,
you
ma'am.
can improve on that repetition what you are having
Yeah.
repetition. Okay,
Yes. Yes, ma'am.
little bit sequential. You initially you divided that maternal risk factor, fetal risk factor, then you got heavy. Okay, maybe
Yes, ma'am.
because you are not preparing or
Yes.
not
Yes.
revised recently. Okay, but do not judge, do not go by the blind way that okay, these are the questions and I am, they are going to ask me these questions only. No, 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 big no. Another another question might be here, classification.
Yes, ma'am.
Classification, classification of third and fourth degree perineal tear or perineal tear overall, they might ask you. So that is another question, be ready for that. So my answer key is very simple in this most of the points you said, but still S bar use whenever the first questions they ask you, use S bar. Okay, a case of 4 degree perineal tear in a, with a, in primary gravida with operative instrumental delivery or forceps delivery. So the overall incidence is, you can mention if you want, you can miss out. The operative means with forceps delivery, the incidence is 8 to 12%. Okay, everybody knew that figure nowadays. So the increased risk of risk factor are ethnicity, nullified parity, birth weight, shoulder dystocia, occipito-posterior position, prolonged second stage of labor, and instrumental delivery. Okay, now
Yes.
how to repair? Yes, dear, any question?
Yes, ma'am. Clear.
Yeah, clear. Now, once identified, the more structured way of repairing is once identified and label it as a oasis, I will inform to the patient. I will introduce, inform to the patient and take a consent for repair. The repair, yes, you mentioned that needs to be done by a trained personnel. It can be ST5 if trained or a senior might be involved. Inform consultant, you are not going to call up consultant, you inform consultant here. An anesthetist, shift to theater for repair under all aseptic precaution in good lighting. Antibiotics, active management of third stage of labor. You are going to assess her general condition. Most of the time, third and fourth degree perineal tear, do you think are they are associated with any PPH? Less likely. Traumatic PPH, yes, you can anticipate. So for that thing, you are going to offer them active management of third stage of labor. You can assess her clinically also. That was good point which I had not mentioned in my answer key, but that was a good point. So I would like to assess her clinically whether there are any uh, active bleeding which needs to be tackled on an impriority basis. I don't think it is obstetric emergency. Obstetric emergency, they have not mentioned in third and fourth degree perineal tear. Okay,
Yes.
so if it is PPH, then it is obstetric emergency. But if it is not PPH, then I will not. So once patient is stable, needs to be sutured as soon as possible, because delayed suturing will cause edematous tissue, and there might be a chances of more traumatic. Because of that edema, the healing might impair, traumatic, it might be traumatic. Okay, so as early as possible you need to go for that. Mm, IV antibiotics, active management of third stage of labor under regional or general anesthesia. Okay, it is not analgesia, dear. It is mostly anesthesia. Hmm?
Okay, ma'am. Yes. Yes.
Okay, so your ST2 or ST5 anesthetist will be involved, not consultant anesthetist here. So informing a theater team, preparing a trolley very nicely. You had mentioned those points. Preparing, instructing the theater coordinator or theater scrub nurse to arrange this suture material what will be required for this repair. Okay, so that will be a specific instruction, you can give it to them. Now if there is excessive bleeding, after in spite of means excessive bleeding or the bleeding which is interfering with your surgical field, then you can put a vaginal pad. Sutures which needs to be avoided are figure of 8. Always mention what you are going to avoid in this exam. So you are not going to put any figure of 8 sutures as they will be causing ischemia. Anorectal mucosa, polygalactin 30, uh, or PDS. Okay, either of the way you can say, not 20. You mentioned about 20. Continuous or interrupted technique. You mentioned, and knots to be buried so that what? No, knots to be buried so that it will not irritate, but the polygalactic less likely they're going migrating or irritating. IAS, internal anal sphincter, interrupted or mattress, it will not be end to end. Okay, or overlapping, no, interrupted or mattress, not overlapping. Without overlapping in internal anal sphincter. 20 polygalactic or PDS. External, either overlapping or end to end, whatever will be comfortable. After identifying the edges, then uh, both the methods are having the means but good outcome or equivalent outcome. This is again 20 polygalactic, rest by 10. Okay, here actually I had mentioned 10 polygalactic, that is the skin and tissues. Okay, subcutaneous tissue. Yes, very important that once the procedure has been completed, per speculum, per vaginal and per PR examination is needed. Swab, needle, instrument count are important in this situation. Patient will be shifted for further care. Documentation is important here now, post procedural. So those are the important points here. See, what will you like to check before discharging her home? So, introducing yourself, inquiring about her well being, you mentioned, mobilization, pain, bleeding, bowel, bladder, you mentioned. Would like to see whether the notes and documentation has been completed. Incident reporting, see, per se, fourth or third degree perineal tear in a primiparas or multigravida patient is not reported, but if it is operative vaginal delivery, then they are saying in any complication of operative vaginal delivery needs to be reported. So that's the reason I have mentioned about incident reporting. Check notes, ensure that everything, every document, means documentation regarding swabs and needle instrument count is completed. Documented. Okay. Where documented as remote? I don't. Okay. uh, Explain. Now here you are going to prescribe her and you are going to ensure that she will continue her antibiotics, and she will be getting her antibiotics for next 7 days. Offer examination if there are any concerns with her repair. If the patient is complaining, then only you are going to offer her examination in the presence of chaperone. Explain the details when you need to come back. When you need to come back, any foul smelling discharge, any uh, excessive bleeding, any fever, she can report with contact details. She needs to be informed. Summary of her care will be completed and it will be handed over to GP for further management. Follow-up instructions regarding perineal hygiene, seeds bath, laxative and dietary advices will be given to her, including pelvic floor muscle exercises. Ensure that you will be giving her patient information leaflet of 3rd degree or 4th degree perineal tear. Details of support group. Support group is very important because that communication with patient and communication with family domain is getting uh, assessed in this domain. Okay, so MASIC is a support group whenever 3rd and 4th degree perineal tear. These are almost similar questions. Both the questions are very similar. What you will be completing prior to discharge and what instructions you will be giving to her discharge. Okay. So yes, reassurance, you very nicely you mentioned that reassurance that regarding the prognosis of repair, that if identified and repaired on time, the prognosis of 3rd and 4th degree perineal tear are very good. Most of the time 6 to 8 out of 10 will have asymptomatic by 1 year, and earlier also if they follow the instructions carefully. So what are the instructions? Dietary advice: not to constipate, continue laxatives, plenty of oral fluids, um, not to resume sexual intercourse, no tampons, take regular pelvic floor muscle exercises, perineal hygiene and care, antibiotics to be continued for next 7 days, to keep a symptom diary. If the patient is having any symptoms, she can have a symptom diary, and a follow-up appointment at 6 to 12 weeks, we can review her symptom diary.
Arrange a follow-up visit with a perineal clinic. Educate on when to call up GP or to report to the hospital. That is very important. So these are the instructions patient we can give her the patient give to the patient. Now at 6 weeks you have seen this patient. So at 6 weeks, depending upon the symptoms, if the symptoms are patient is asymptomatic, then patient can be discussed. We can discuss. Here actually at discharge again we are going to discuss one more point here. I had not mentioned. I think I forgot to mention regarding the baby breastfeeding. Hmm? Very important dear here. Baby and breastfeeding. Not to forget about baby and breastfeeding, even including mental health. Sometimes this might be and traumatic event for the patient, so mental health is also important. So we need to tell her about regarding the signs and symptoms when she needs to come up for follow. So that is also one of the important points which we have to tell her. Review her symptom diary at 6 weeks. Ask her about sexual intercourse and contraception. If not, you can guide her for contraception. Inquire about baby and breastfeeding. Inquire about her menstrual health. Sometimes it might trigger a postpartum depression. If asymptomatic, we can examine vagina and do a PR. If asymptomatic, we can discharge her to the primary care. If symptomatic, then we are going to examine her per vagina PR, and then going to arrange further investigations, which will be ultrasonography and manometric or pressure studies, and this will be referred. The patient will be referred with these studies to the MDT, which will include colorectal surgeon at 12 weeks of time. Till that time, perineal hygiene, pelvic floor muscle exercises, and then means coping strategies. If the patient is having symptomatically, she's really having trouble with managing her symptoms. Till that time, patient can be given coping strategies like anal plugs, toiletries, pads, scented products, and patient can be seen at 12 weeks by the MDT to decide regarding the further care and further course. How will you manage in her next pregnancy? Depending upon the symptoms, patient can be managed. If asymptomatic, she can be managed at the community level also. Okay. Consultant led unit, they have not mentioned that previous third or fourth degree penalty, but one more important point is here: OAC's care bundle plan we need to offer this patient. So what are these OAC's care bundle plan? You have to elaborate and tell it. Do not say that only. What are these points? You have to explain that. If the patient is symptomatic, then anal manometry, ultrasonography scan. Scans are normal or not, depending upon that the mode of delivery. If if asymptomatic, then vaginal delivery. If the symptoms are there, then the patients can be given the options of or cesarean section. There in this book they had mentioned that if the patients are means symptomatic and patient needs repair, not repair, so we can allow her to go for vaginal delivery, and once the after the vaginal delivery, we can repair her complete perineum. So far as the RCOG guideline has not mentioned anything like that, so I have not mentioned it into the answer key. But what is a safer way of explaining her regarding her next pregnancy? It is symptomatic or asymptomatic. Asymptomatic, nothing to worry, can be continued as it is. Can go for vaginal delivery. If symptomatic, then yes, anal manometry and ultrasonography will decide if the defect is more and the pressure changes are less. Then in that case, she will be discussed option of cesarean section, or cesarean section is recommended in that case in her second pregnancy. So that is what the guideline is saying. So I will be strictly going according to the guideline, along with that other management what we have discussed right now. Now coming to the score, information gathering. So what are the information gathering here? Actually, the symptoms information has been given to you in the first instance. Then symptoms, what symptoms she is having, examination, information prior to discharge regarding her bowel bladder habits, examination and investigations. What investigation you will be offering if the patient will be symptomatic, uh, plan, subsequent plan, how will be your subsequent plan? That is also important point. Symptom diary and offering examination whenever needed. These are the information gathering in this domain. Communication with colleague, So when you can involve, when you need to involve the senior, and when you need to, when you can do these cases, so you need to be aware when to involve the senior or when to take a senior's help in the management. What exactly you are going to explain to the senior, that also we need to list, means we need to plan the management and communicate easily understood, suitable language in a better way to the consultant team. So mdt is what here? Physiotherapy, perineal trauma team, rather than colorectal surgeon will also part of team if the patient will be symptomatic, gp and community midwife. So this will be all in the communication with colleague domain. Patient safety. Understand risk management and clinical governance process in relation to investigation who develop third and fourth degree perineal intrapartum. Say prescription allergies if are there expected. So this was actually they had mentioned, but I don't think. Principles of repair, how you are going to repair third and fourth degree perineal tear. Reassurance regarding the prognosis, explaining her about post surgical care and red flags. These will be the patient safety points in this case. Applied clinical knowledge, we all know, we all are very well versed with the knowledge about third and fourth degree perineal tear. That is what we are needing, and knowledge about oasis care bundle plan is also important. So can somebody summarize for me what is oasis care bundle plan? Anybody? Muthulakshmi? Am I audible?
Yes, ma'am, audible.
Yes, ma'am.
Okay, so what is oasis care bundle plan? Only 2 3 points are there. Perineal massage, from when actually you are going to offer to these patients if they get pregnant? From 35 weeks onward. Yes, yes or no? Then,
Weeks, I'm not sure, ma'am. Perineal
yeah,
massage, I'm remembering. Weeks, I'm not sure.
yeah, I think that is 35 weeks onward. Okay. Second point is liberal episiotomy. Okay, whenever it is needed, you will consider episiotomy. Warm compression during labor.
Yes, next pregnancy.
Okay.
Perineal protection.
Yeah, perineal protection. Welcome, Tania.
During crowning.
During crowning, perineal protection during crowning, and
Mediolateral episiotomy, ma'am, and examination per rectally and per vaginally after the repair during the antenatal.
yes, yes, yes. Yeah. So, and please mention this actually, dear. Please mention this. It is very important. Hmm? Okay.
Yes, ma'am.
Yes, ma'am.
Okay. Any question regarding this? Any question anybody is having?
Clear, ma'am.
Clear. Okay. So this is one of the, because this is newer guidelines. So whenever there are newer guidelines, the topics are most of the time getting included. Please ensure that you will completely aware about the new, which is the newer guideline just now come up.
Varicella zoster, ma'am.
That is just a one upgradation. Okay, one addition is there. That means addition of cyclovir. Okay, that's it.
Hysteroscopy.
Up, yes, it is hysteroscopy. So you can expect a station about hysteroscopy also. At least not in this exam, but the next exam. Okay.
Yes, ma'am.